We'll do our normal sound check here and make sure that the participants can hear us and they're popping in. I can tell you this is always a hot topic. I've already gotten questions coming through email as of yesterday. I got people sending questions, so we already got some of those lined up. All right, can somebody give me a sound check? That would be fantastic. So Simone or Mary, Lydia, I'm seeing your names, and welcome everyone. If you could tell me in the chat that we're good on sound, then we're gonna go ahead and get started. A little forgiveness and grace on my part as I'm trying to avoid getting a cold, so I might squeak and croak a little bit today. Awesome, thank you so much, you guys. We are streaming live into Facebook. As always, you guys, if you have questions, please put them in the Q&A. If you're on Zoom with us, in the Q&A is where I'm gonna be tracking questions. If you're on Facebook, I'll do my best to go out there and check questions there as well. I also take a little bit of notes when I'm interviewing. So if you see me looking down, I just wanna give you a heads up because that helps me to remember the things that I may wanna ask. So today, we are welcoming back Dr. Rosensweet. He's the medical director of the Menopause Method. Their mission is to change the world for women in menopause by championing organic-based hormones and the expert administration of them. Dr. Rosensweet has been a holistic medical practice for 4 decades. He was the clinical trainer of the first nurse practitioners in the USA. He was in charge of health promotion for the state of New Mexico, and he organized a summit on treating women in menopause in 2004. He's the inventor of a patented certified organic base for women's hormones and has written a book on menopause, now in its 6th edition. He spends the majority of his professional time training and mentoring physicians and nurse practitioners in treating women in menopause. So today we're focusing our attention in the webinar on the synergy that's possible with health coaches in assisting women in menopause. So he's going to address what health coaches are facing and what value you guys might add. And as we know, health coaches have so much value. And I just want to say, I've said it before, I'll say it again. I'm so grateful for you guys just like really welcoming health coaches in on this movement that we're in, Dr. Rosensweet. It's really refreshing to hear people that we respect like you saying how valuable we are. So welcome back and thanks again for spending time with us today.
Thanks again for connecting up with me, Carmen. It's a pleasure to be here. And hello to everybody out there.
Yes, awesome. So we're going to dive right in because this is a big topic. And as we start talking, and our organic conversation can always bring up more questions. So let's talk about how early menopause starts. When do you see that beginning for people?
Well, there's a couple of highlights along the way. I think the first one to become aware of are the subtle symptoms that can occur in the early 30s, no problem. And then from there on, they can get stronger and stronger and stronger. And of course, it varies woman to woman. Mm-hmm. So in some women that I interview in their early 30s, I can tell it's happening.
Really?
And really, and then some women, it more of a falling off of a cliff when the periods stop. Subtle, okay. And some falling off a cliff when the periods stop, and others, and everything in between. As a health coach, I think what's really good for you to be able to identify is when women's hormones start declining to the point that it can be giving them difficulty. And is it possible for me to share my screen? I think I could illustrate this.
Yes, please do. And if you see me muting, it's because,
tell me if you can see it and what screen you see. And I'll be brief on this, Carmen, but I think this is some of the best information for health coaches.
Okay, yeah, I see it, and you're good with slides. We love visuals, and if you see me muting, it's again, you guys, I have a sick kid home, and I've got some dogs running around, so I'm engaged, but I like to mute so we have no distractions. But this is great. I love to see a visual.
So this is different aspects of the menstrual cycle, and what I want to zero in on is what's going on hormonally. This is really about what's happening to the uterus lining. This is days of the cycle, 1 through 27. This is what's happening in the ovary around ovulation, if ovulation takes place. This is what's happening in the pituitary. But let's look at hormone levels. Mm-hmm. And this is the classic representation of what goes on in a woman's cycle. Days 1 through 28. 28 should be out here. Look at this mid-cycle burst of estrogen, followed by a decline. That's the red line, that's the estrogen, following by an increase back, a rise of estrogen, and then ultimately a fall. And it's that final fall that triggers the menstrual cycle. Let's look at what happens with progesterone. Low, low, low. And progesterone will rise mid-cycle if a woman ovulates.
Okay.
Doesn't ovulate, it's going to stay low. And in fact, in a young woman, if she's got regular cycles, this is the time to test her, because she's high in, she's going to be at a maximum point in both progesterone and almost maximum in estrogen. Mid-luteal, it's called.
Okay.
Now, that classic graph doesn't really represent what's truly going on, because progesterone levels are 100 times what estrogen levels are. So I just use this slide to illustrate that how important progesterone is to a woman.
Yeah, please.
I
know.
Go the chart, and that's what I'm trying to illustrate.
Yes.
100 times more progesterone in this phase of the cycle than there is estrogen. That is, if a woman ovulates.
Right.
This little dive of estrogen. I had a consultation with one of my patients today. She never had migraine headaches in her life until she got into her 40s. And when would she get them? They were classic menstrual migraines. They took place when the estrogen fell. And she'd get them at the end of the month, because that's when the estrogen collapses the most, or she'd get them mid-cycle.
Okay.
When the estrogen falls there. Why I'm mentioning this to health coaches, there are a certain number of women, if they've never had migraines in their life, or migraines were pretty rare, and then all of a sudden in their 40s or 50s, they're getting once a month or twice a month migraines. That's a real alert that they're getting into some very low estrogens, even though they're still menstruating.
I've had clients with that in the past.
Yeah. And then, actually, I want to go to this slide. This is a little bit of a complex slide, but let me try and zero in on it. This is the, on the lower axis here, there is the age of a woman, 25, 35, 50, 60, 75. And on this axis, there's levels. And notice how by the age 25 or even earlier, the estrogen and progesterone are starting to decline. Actually, a woman's maximum levels of estrogen and progesterone are really somewhere between the age of 18 and 22.
Wow. And
from that moment on, usually by 22, her hormone levels are starting to decline.
Yeah.
And then look at this. Progesterone is declining earlier.
Okay.
This is the age here. Estrogen is taking a little longer to decline. Progesterone can decline more profoundly and earlier. And this is the piece of information that I think is so important for a health coach. Because if you can pick up when a woman's starting to experience low progesterone, you can do a lot of good for her, and you actually can have a tool. And it's, you can treat her with progesterone because there is over-the-counter progesterones. So when a woman is, how would you detect this moment? Well, if there's relatively, the estrogen's declined, but if there's relatively less progesterone than there is estrogen, then the effects of estrogen are going to predominate.
Right. Right. So can we just, can I say something here real quick? I want to make sure that we're touching really strongly on this point, because when I learned about all of this, and I love Dr. Michael Lamb, I've followed him for quite some time, but I'm loving that you're touching on this part, because I've had many people in the past, many clients I've worked with, that said to me, well, how can I be estrogen dominant? How can that be possible and have my ratio be this or this? You see what I mean? They're very confused about it. So even if your hormones are rock bottomed, like let's say they're both low, people don't understand that estrogen can still be above progesterone, even if both hormones are showing low, right?
Yes.
Okay, that's an important point.
Think of it this way. A woman's hormones maximizes out. Let me see if I have a slide that illustrates this. I'm sorry to.
No, you're fine.
I don't have one that I can easily put my hand on.
Isn't it interesting, though, the progesterone, just the hormonal layout that you gave us there about how between the age of 18 and 22, their hormones are at, at their peak. I mean, that's got to be evolution. We were having babies a lot younger than we are now years ago, right? Is that part of the reason?
And why in the world would they decline? Because the demand on producing a lot of hormones is pretty high.
Mm-hmm.
And we always think of the stress response as recruiting adrenaline and cortisol.
Yeah.
And indeed it does. But it also can utilize a woman's estrogen
Mm-hmm.
and a woman's testosterone.
Yes.
And estrogen, one of its main functions is to stimulate the growth of the uterine lining that a woman menstruates once a month.
Mm-hmm.
And you have young women athletes who are overtraining. A lot of those women are not menstruating.
Right.
Recruited the estrogen not down the female pathway. They've recruited it to go down the stress pathway. They're not menstruating.
Right. Yep.
And, that's a pretty intense stress in a young woman. Well, all of us, male and female, we tend to be having different levels of expertise on how we handle the stress response. And we tend to, especially when younger, trigger the biology of that stress response. Thus, we're depleting all of our hormones.
Right.
We're depleting thyroid, we're depleting adrenal, and women are depleting ovarian, and men are depleting testosterone.
Yeah.
There's a lot of young men with erectile dysfunction that, where in the heck did that come from?
Right.
Long-term stress. Well, women are producing the peak amount, and I'm just zeroing in on estrogen and progesterone, 18 to 22. From that moment on, both of these hormones are declining.
Mm-hmm. Yeah.
So a woman who is 30 has less estrogen than she's had since she went into when she was young.
Right.
Now, here's the issue, and that Dr. Lamb points out, she could have even less progesterone.
Mm-hmm.
The loss of progesterone oftentimes occurs earlier and more intensely than the loss of estrogen.
Mm-hmm. And that's our pro-life hormone. Hello. I mean, if we're not having babies till we're in our 30s and we're losing progesterone, no wonder women are struggling to get pregnant, right?
That's a big part of it.
Yeah.
And here's the other thing. Estrogen and progesterone are in lovely balance with one another. Estrogen stimulates. Progesterone quiets.
Mm-hmm.
Estrogen stimulates breast glandular tissue once a month to prepare for lactation in case there's an implantation.
Right.
Progesterone quiets breast glandular tissue.
Right.
If you have a falling down of your estrogen, but you've got more of a falling down of your progesterone, the estrogen, even though it's less than it's ever been, is still going to be relatively more proportionally increased over the progesterone. You're going to get estrogen stimulatory effects. A woman's going to have breast tenderness, uterine cramps. Even though she's dealing with less estrogen than she's ever had, she's even got lesser progesterone.
Yes. Yes.
This is what health coaches should watch out for.
Yes.
You have a tool there. It's to identify when that progesterone decline happens.
Yep.
So if a woman says, I was fine during my 20s,
Mm-hmm.
but now I'm having a little sleep trouble, I feel a little more anxiety, oops.
Yeah.
A little more anxiety, not getting that calming effect of progesterone. I'm starting to get breast tenderness and period cramps that I haven't had for 10 years. Oops. Those estrogen stimulation forces are predominating over the lessened progesterone. You can give her over-the-counter progesterone.
Yeah. See, isn't that gosh, it just sounds so stinking simple. Like, where were you 17 years ago when I started the journey of trying to have a baby, right? Yeah. And all my stuff went down the toilet. But yeah, so this is important stuff because so many times I'll say a majority of the time we don't even think about this. We think, oh, she's not sleeping well. Her melatonin is low. Her cortisol is high. Let's do adrenal testing. Let's do this. And we're jumping right over this very obvious thing. It's so simple, right? So what's the next step? So let's look at this health coach perspective. Client comes to them, has the symptoms you just mentioned. They know about this, right? Because they've attended this webinar. They now know that this could be a low progesterone or ratio issue, P to E. How do they get the verification that could be the problem? How do they refer out? How do we go about getting that data?
Well, there's a couple choices here. I mean, women themselves can treat themselves if they have this amount of knowledge. They can go do what they've been able to do since the 80s and go out and purchase some over-the-counter progesterone from their health food store.
Mm-hmm.
You say, well, you're playing with hormones, and should you be doing that? I just want to illustrate that this has been available since the 80s, and there have been a certain small percentage of women who picked up on this information and did themselves some terrific good by augmenting over-the-counter progesterone, which is weaker than the common progesterone that is prescribed.
Right.
And then, well, health coaches could educate themselves more about this and could pick up on that the clues of when a woman's getting estrogen dominant effects with lessened progesterone, and do the woman some good by giving her some progesterone.
Mm-hmm.
And then there comes the magic moment in a woman's life where the health coach needs to ally with a prescriber.
Mm-hmm.
Because I know there's a lot of information about there about remedying hormonal decline and the various herbs and various measures you can do. But I tell you, I've never seen them really do the job.
Right, right. So you know what I love? Go ahead.
So it really amounts to allying with a physician or a nurse practitioner in their area or in their state, because telemedicine has opened up the options here terrifically. So if you were to form a professional relationship, which is such a win-win relationship,
yeah,
physician or nurse practitioner, they can serve a health coach tremendously, because you really want to identify when the woman actually needs hormones. And you don't want to delay that.
Right.
And the reasons are, as that estrogen starts to decline, you start getting into bone loss, just for openers, cognitive issues, the whole vaginal issues, and you want to pick up on that early. And you want to pick up when the androgens start to decline, like testosterone and DHEA, because you don't want to lose muscle. Anyone could look at their triceps right now, and if it's a little more flabby than it used to be, you got androgen deficiency and you're losing your muscle. And you know, catching it in the 40s is wonderful. And if it's not caught, this is why women get into canes, walkers, and wheelchairs in their 70s, 80s, and 90s.
Right.
This is why they start wearing Depends, those adult diapers.
Yeah.
Because the muscle that holds up the bladder is lost. Sarcopenia, it's called, loss of muscle mass.
Yeah.
You couple that with the vaginal issues, and you got bladder issues.
Mm-hmm.
The greatest good that we can do for women is the earlier, the better.
Right.
Now, I want to go back to affiliating with a nurse practitioner or physician. If you send us, if it's okay with you, Carmen, your email address, we have a woman on our staff that you've spoken to, I think, Carmen, Sherry.
Mm-hmm. Yep.
And she knows every one of the nurse practitioners and physicians that we've trained in this country.
Yep.
And we don't have every state covered, but we're working on it. We're in the phase of getting it covered in every state. And it's such a mutually beneficial relationship, because if you've got a busy practice and you've got someone with diabetes, you can't just say to the person as a physician, now go take care of your diet. You know?
Right.
And every health coach out there knows that it's a slow moving train sometimes to help someone change. And it takes a lot of input. This is why I'm so excited to work with health coaches.
Mm-hmm.
Know the crucial place. But we need to do the hardest part in medicine is implementation.
Right.
Doesn't matter how many good ideas I have or how much I know. It's how do you hold someone's hand and stay with them as an individual and help them institute the dietary and exercise and detoxification and supplements and hormones that you need. Well, it's such a win-win relationship, so we like to link up health coaches. And sometimes you develop a relationship that's a win-win financial situation as well. And we really like that too, because we all got rent to pay.
Yeah, true. All right, I'm going to ask a couple questions here. let's see here, that came in through email. One of them was, how much control do you believe we have over menopause symptoms and our clients as well, you know, of course, via the food that we eat? Like, how much control do we have over that by what we put in our mouths? Because, you know, a lot of people claim, they have big claims out there. Well, if you don't eat this and you eat this, this is going to be control, you know, your hormones. I've heard that before.
I hear that. And I've had this unusual privilege in the course of my medical career to work with some of the most intelligent, most motivated, most health conscious, most committed women that you could imagine. That's been a great privilege.
Yep.
And they were the ones who sought out the hormones. And so many of them are on as good a diet as you can get.
Right.
And they're on as good an exercise program as you can get. And these hormones are so strong that if I had to make a wild guess, I would say a very, very tiny percent of hormones can be affected by nutrition.
Yeah.
Really, if your overall health is good and you're taking care of yourself with impeccable nutrition and impeccable exercise, and you do well with the stress response, well with the stress in your life. Notice I'm not saying get rid of the stress in your life. I'm saying don't trigger the biology of the stress response, which everybody does.
Right.
You're going to get into a major hormonal depletion, and the chemicals that are used for fight or flight are so strong. I just don't see diet being able to influence them very much. So if I had to make a wild guess, I'd say 1%, 2%.
Right. I would agree with you. And I would say that, I mean, you know, I would say that the first place that we need to look, and this is my opinion, my own personal experience and 10 years of working with clients, is how are they perceiving the stress in their life? Not how are they managing it, not how are they reducing it? How are they seeing the things that are happening in their lives, and how are they dealing with them? Is it appropriate? Are they triggering that response over things that don't need to be triggered over? Things that, you know, my famous saying, nothing's an emergency but an emergency. But we live our lives in a state of emergency. Even things that aren't an emergency, I've seen clients go off the rails, and I'm like, you know, you're just 5 minutes late. It's not, you haven't forgotten your child at school. You're just 5 minutes late. Let's dial it back. Let's see it what it is. Let's be kinder and gentler on ourselves, right? I think it's a work in progress, because isn't that the top of the tier when it comes to our sex hormones, is how are we doing this stress thing in our lives?
Yeah, because if we're not doing it well, we're going to call forth that estrogen and that testosterone and that DHEA, recruit it. It really does empower fighting or fleeing. And it's just, I test a lot of women.
Yeah.
And I can tell you, every woman in their 40s and 50s have depleted androgens by then. Almost everyone.
Yeah.
It's a big deal.
Yeah. I'm one.
Stress. Yeah. And of course, the lower estrogen and progesterone.
Yeah. Yeah.
And
go ahead.
The thing I wanted to mention is that I don't want to forget is somewhere along the line, I want to tell you about the tool that we've developed. It's in manufacture right now. We're producing the progesterone over the counter in our organic oils, which I think is a big deal. Yeah. And I'll say more about it later. But if we get your email address, we'll notify you when that product comes on the market. And what we envision for health coaches is that you could purchase it wholesale directly from the manufacturer and have it there right on your desk.
Right.
And say, okay, we see that your progesterone's declining. These aren't prescription doses, but it's a good time to start with the progesterone.
Okay. So we have to remind coaches, just let me throw this reminder in there on my own, waiver of disclaimer, is that my thing is to recommend and suggest. So, if you were a person that were able to get these oils wholesale, it's a recommendation. You're not prescribing anything to them. So just, I always have to say that, because I want to make sure coaches know when we do these webinars, we are the support for people. We're just making suggestions or recommendations of these things. We're not giving them a specific dosage or anything to do with it.
Yeah.
So I want to throw that out there.
Yes. And I'm glad that you do. And you might want to have different guidelines because it won't be long before they're going to need prescription levels.
Yeah. Yep.
And it's so desirable to catch women early. I mean, I've started treating women in their 70s and 80s, but that's not the best time. There's been so much lost by then.
Yeah. Yeah. So that's a good question here we've got from Mary. Can menopause and hormones cause joint pain that cause limited range of motion?
So many women come into menopause with a lot of symptoms, a lot of mysterious ones.
Right.
And one of them is pain. And I'm going to tell you about a 55-year-old real estate agent that I was working with once on the first visit. She was a high-end real estate agent, very successful. And I'm reading her initial questionnaire and I go, she's on daily OxyContin.
Oh my gosh.
And I'm sitting there going, do I really want to get involved with an OxyContin addict?
Yeah.
And she was on it because of severe pain, severe joint pain. And she seemed very intelligent to me, so I sort of suppressed any concern I had and just went forward. 5 weeks later, I get a call from her saying, I'm totally off the OxyContin. All my pain is gone. These hormones did it.
Wow. And what was it the majority, do you think? Was it progesterone, the relaxation hormone? Or
both of them.
Okay.
Estrogen deficiency for sure, progesterone. Yeah. And I'm giving you an extreme example, but one of the things that we teach physicians and nurse practitioners is a woman of perimenopausal or menopausal age can come in with a long list of possible grievances, symptoms, and signs. And if nothing stands out to you, treat the menopause first and see how many of those disappear.
Right.
Shocking, and including pain. And that's what I wanted to say about the pain.
Yes. Yeah.
Carmen, excuse me, I wanted to drop back to one thing.
Sure.
That one of the biggest services we might be able to do is to link up any health coach that is interested with physicians that we know are treating women in menopause. And if they get me their email address, I'll pass it on to Sherry. And they'll go onto a list, and the ones that we have physicians and nurse practitioners in their state already, Sherry will email the health coach the name or names of active physicians and nurse practitioners in a state. And otherwise, we got such an active process going on that if their state comes online, we'll then if they want that.
Yeah, absolutely. Are you kidding? I'm sure. First of all, let me just remind you guys, I see you putting questions in the chat. I'm only reading from the Q&A and we're loading up already. So please put them in the Q&A. Where would they send their email address to? What email, where's the best place to send that to?
Can I, is there some way that I can put it in a chat?
Yeah, you should just be able to click on chat and it says type message here. If not, let me know and I'll type it in for you. And Mary's saying, Sherry sent me when I'm scheduled. Can't wait to start working with the doctor. That's awesome. And I'm just kind of scrolling through here. Makes me feel hopeful. Yeah, okay. It's going too fast. Okay, we got a lot of questions, you guys. We have until 1:30. So keep that in mind as you're plugging in questions. We can't get to everything. We do have, and I do want to say this too, that Simone brought to our attention here as you were sharing your screen, Dr. Rosensweet. She said, this isn't really on topic, but you have over 31,000 emails and over 5,000 unread, but here you are sitting with us, and she's just so grateful for that. So, yeah, when we share our screens, you never know what you're going to see in the background. With me, same thing. But again, so let's be courteous of time, and let's get to more questions here. Linda is saying, have you seen heavy metals attaching to estrogen receptors? She's postmenopausal on BHRT for a number of years, but the symptoms of estrogen deficiency persisted until now. She's been doing metal detoxes and things like that.
Absolutely, and it's a good point. And the world expert on this is a physician named Lindsay Berkson.
Oh yeah, we know Lindsay. I've interviewed her. Yeah, she's great.
And really, we're talking about this whole subject called receptor site disruptors.
Yeah. Because
estrogen and progesterone bind to these estrogen and progesterone receptor sites, and so does junk. Yeah. Yeah. And there are all kinds of these disruptors. Heavy metals, they're one. They bind to a lot of stuff we wish they didn't bind to.
Yep.
And then also these petrochemicals. And Dr. Berkson has a long list of stuff that binds. And then I don't know how many health coaches are have taken on the subject of detoxification, I think it's a wonderful thing for a health coach to do that, because very often the physicians aren't necessarily that educated in it.
Right.
And the patients need their hand held through the various methods that aren't that complex, including sticking a heater in your bathroom and getting it up to 104 degrees. That'll blow out some of the petrochemicals that are bound to these receptor sites.
Right. So can I clarify real quick, if you don't mind? A lot of people don't understand that even that technology or that terminology of receptor site and binding and all that. And we're talking about kind of a lock and key situation here, where if we've got a key that the key may be, estrogen or metal. Let's say the metal that the key looks like metal, and the receptor is over here that's supposed to accept hormones that we need, and a metal might go in and plug up that hole. Then those hormones we need can't get into those receptors, right? And I'm doing kind of a gross visual here, but you get what I'm saying. If something's blocking the receptor site that the hormone is supposed to go in that we need, that helps us be healthy, like metals or pathogens or petrochemicals, then the hormones can't get into where they belong, and then we become deficient. I like to do a little bit of that visual stuff, because sometimes
I'd like to even pause on that one a moment,
Yeah.
because, everyone hears, well, we have hormones, and then the question is, well, how do they work?
Right.
And oh my God, it's extraordinary. If you don't believe in divinity now, take a look at the biochemistry of how hormones work.
Yes.
I mean, you apply a hormone to your skin, or it comes out of the ovary, and it gets into a cell, and it gets into a cell nucleus, and it starts communicating with the DNA, and the DNA produces a protein, it produces effect. This is quite a biochemical change. But what Carmen was referring to is, if this is the hormone, it just can't go into a cell and do exactly what it does. If this is the cell, it's got to go into the cell, and it'll be contact with a receptor site, it's called. And when you get down to super magnification, you see that these hormones are chemicals, and they link up with these protein structures called receptor sites. And they're very specific, and they're a little bit non-specific. For example, for estrogen to work well, you have to have alive and well estrogen receptor sites.
Right.
For progesterone to work well, you got to have alive and well different receptor sites called the progesterone receptor. Same is true for thyroid. There is some cross reactivity there. If you flood a woman with progesterone, even though estrogen binds best to the estrogen receptor site, progesterone will also bind to the estrogen receptor site. Not as well, but if you flooded an excessive dose of progesterone into a woman, it's going to bind up some of that estrogen receptor site, and it can even kick estrogen out of the receptor sites. I'm getting a little technical, but it's worth knowing that you can mess up through inaccurate treatment the balance between estrogen and progesterone. And estrogen binds best, progesterone binds to it, and so do metals, mercury, lead, cadmium. Oh my God, they will bind to those receptor sites and mess them up.
Yeah.
They can bind pretty tightly, and so can petrochemicals.
Yeah, so that's another area we belong in, is health coaches, is giving people information about all of these outside environmental toxins and things that are affecting people that they don't realize. When their yard looks beautiful and green and not full of weeds like mine, it could be from what's being sprayed on them once a month. It's beautiful, but guess what's happening to your health? So another great area for health coaches to play a part in is all of those. I think
that's a crucial area and worth pausing on. I can't tell you how many patients that we had to do a march through their home and yard.
Yeah.
And the best way to do it is a health coach do a house call, or at least describe, here's what we've got our house down to.
Yeah.
Distilled vinegar, a little Bon Ami.
Yeah.
Every one of those household products there's just such an enormous amount of them, they're gone from our house.
Yeah.
And then you mentioned the lawn stuff. That's much worse. If you got a chemical strong enough to kill a weed or kill an insect,
Yeah.
you're going to harm the human being. So I'm
Yep.
glad you brought it up, and it can be a knowledge base and a piece of work for a health coach to march through someone's home and the detergents that people use. We
Yeah.
use a seventh generation laundry detergent. That's
Yep.
another household product we have. We use seventh generation dishwasher soap.
Me too. Same here.
They're
Yeah.
not perfect. Even seventh generation is not perfect. Take a whiff of it.
Yep.
It's got some chemicals in there, and some of them are strong, and it's got some odors in there, even the free and clear. But my God, a cleanup. And it saves people money. They don't buy these dryer things that you stick in there that stink up the dryer and
Right.
stink up the clothes. And
Essential oils and wool balls do just as good of a job. Okay, we got a lot of questions. We're going to have to keep moving here. Linda wants to know, can you explain the importance of coming off BHRT monthly? What are the problems that can occur if you do not? I love that question because I think I've always heard a honeymoon is a good idea.
we're very specific about that.
Mm-hmm.
We recommend that once a month, a woman stop all of her hormones.
Mm-hmm. For how long?
And we do a trial period, and we say to the woman, stay off of them until you develop your first symptom of insufficiency.
Okay.
And the most common thing that happens, not the only thing that happens, is day one off the hormones, the woman's doing pretty well. Day two, pretty well. Day three, she wakes up and she has a hot flash.
Mm-hmm.
What does that tell us? That her hormone levels dropped so low it started triggering a strong symptom. So if it took 3 days to get there, we say from then on, stop 2 days a month.
Okay. Great. That's a great way to do that.
And there's other symptoms, and I'd like to give people who don't have it a no-charge PDF version of our book. And we, again, if we get your name and the request for the book, I'll email you a PDF copy of the book. And we go into great detail about this.
Mm-hmm.
Now, how long is that holiday? I don't like why I say if it took 3 days to get the hot flash, just stop for 2 days. We don't need to throw a woman into a symptom.
Right.
It's a little stressful, and it can throw off a good balanced hormone program.
Yeah.
And then why stop at all?
Right.
Because if a woman is taking 5 more molecules of Biest a month than she actually needs, she may be storing that Biest in her adipose tissue. These are fat-soluble things. If anyone's got any extra fat in there,
Yep.
you're going to develop a strategic reserve of these hormones in your adipose tissue.
Right.
Well, 5 molecules a month, it's going to take you quite a while before you get into excessive estrogen.
Right.
That's why we stop.
Yep.
We prevent that gradual, slow buildup if there happens to be an excessive prescription in there.
That's great. Good explanation. I hadn't heard that before. All right. So we have Lydia saying, can you talk a little bit about the gut microbiome on hormone production? Hold on a minute. Well, in the second part of your question, Lydia, we're not treating with BHRT and avoiding stress management in food at all. We're not doing that. So let's just talk about the effect of the gut microbiome on hormone production.
Yeah. Ultimately, the most important thing is to get a woman, an individual woman, on the optimal doses for her. Now, here's the deal. If you apply topical, let's say, Biest,
Mm-hmm.
which is the way to apply estrogen, is to the skin.
Yep.
It's going to go circulate around her whole body. It's going to be utilized in the cells. And then it's going to be processed in the liver, metabolized. And some of the metabolic byproducts are going to go into the bloodstream and get excreted in the urine via the kidney.
Right.
And a certain very significant percentage of them are going to go into the bile. These steroid hormones are fat soluble, and the bile is a nice conveyor belt.
Mm-hmm.
And from the bile, they're going to go into the gut. And a healthy biome, some of that bacteria are going to break down the processed estrogen and metabolites What happens in the liver is ultimately the processed estrogen is going to be bound up to glucuronide or a sulfate. That's going into the bile.
Okay.
Bile goes into the intestinal tract, and a certain very significant percentage of that little particles in there in the gut are going to get broken down by the gut bacteria. You're going to get free estrogen again, and it's going to recirculate. It's going to go back into the body. It's going to get absorbed by the intestinal tract.
Mm.
So what it really does is it's an ecologic use of a woman's hormones. She gets some recycling there.
Mm-hmm. Yeah.
If she's got a very disturbed microbiome, that's not going to take place.
Right.
So what that translates into is you may have to administer her a little more hormones.
Okay.
But these kind of, so that's a technical thing.
Right.
Everyone should have their gut repaired.
Of course, yes.
But as far as a physician or nurse practitioner prescribing hormones, you just try and help the woman arrive at symptom relief.
Mm-hmm.
Then you do the 24-hour urine hormone test on her. Oh, let me emphasize 24-hour urine hormone test and not the dried urine. Oh, maybe someone will ask me a question about that.
Well, you know that's the question because we asked it last time, and we, yeah.
But at any rate, you do a balance between alleviating a woman's symptoms, and she says, I feel good. And then you test her. And you've got her at the proper hormone level.
Right.
You may have to tweak it after testing. In fact, 75% of the women that you test, they'll be close to the optimal range, but they won't be in it. 75% of it won't be in the target.
Right.
So you tweak the dose a little bit.
Okay.
So how the microbiome could come into effect is if a woman arrived at a dose when she had an unhealthy microbiome, and then simultaneously she's getting her gut straightened out and getting a healthy flora, she could go into symptoms of excess, theoretically.
Right.
I hope I made that clear. Why would she go into symptoms of excess?
Right.
Because all of a sudden, or not all of a sudden, but as her microbiome got normalized, the estrogen that came into the gut wouldn't go out the feces as it would with the unhealthy microbiome. It would get what the common process, it would get recycled, some of it. So now the high dose that you started her with, you repaired her gut, she may need lesser.
Right.
How would you detect that? She starts off her healing program by getting her hormones tested and replenished, and she arrives at a certain dosage level and she says, thank you, I feel good, and she tests well.
Right. It's data. We need data. We need to see this.
And then someone takes on the gut project.
Mm-hmm. Right.
And at the beginning of the gut project, you see, oh my goodness, there's a dysbiosis there, a rather remarkable amount. And they go on a 1, 2, 3 month, 6 month, year gut repair process. And into that repair process and the restoration of a healthy flora comes these normal bacteria that can cleave biased and the metabolites linked up with the glucuronide, thus release the bias now. And all of a sudden, this goes back into the woman's body where it didn't before. It used to go out the poop.
Mm-hmm.
She gets elevated levels, and what she'll tell you, I was really on a wonderful hormone program, and then you repaired my gut, and now I started getting breast tenderness.
Yeah.
Symptoms of too much estrogen.
Wow. That's fascinating. Seriously.
So you address that.
Yeah.
You say, well, gee, maybe we want to lower your dose. You'll read about this in the book. If you want a PDF copy, you can also get a Kindle copy or a hard copy at Amazon.
Yeah, well, you guys, if you're on this list, we'll share the link. I still have the link to the book. And let me just say this: we're getting way too many questions about where do we contact, or giving me your email. Don't give us your email here, you guys. The email address he provided for you is in the chat. It's dr.r@menopausemethod.com. It's not Cherie It's not, just go to the chat, please, and grab that email address. But giving me your email address is not going to get you this book or any information. So please go to chat, grab it there to make sure you guys, I don't want you to miss out on this. It's valuable information. So I'm deleting emails. So go there, please. Okay. Another question. Linda, do you start?
So you can give them the link to give them the free PDF.
Yeah, we're going to do that. We're going to send that out in the email, and then we're going to post it out there on Facebook as well. So we'll definitely get that for you. Linda is asking, do you start with estrogen and progesterone and add in DHEA and testosterone if necessary? Or do you put them all at once?
Most commonly, it totally depends on the woman.
Okay. So you commonly do ENP.
Or in perimenopause, my favorite way to do it is to prescribe 2 bottles, estrogen biased and progesterone.
Right.
Because I always have the theory that if a woman can just work with those 2 variables, she can get a feel for them.
Right.
And thus, 6 months later, if she starts getting estrogen deficient, she'll know, oh, wow, I'll just add a little estrogen here. So she gets an internal feel. And then once she says, wow, I think my hot flashes are gone, I think I've really improved here. If they need androgens, I'll start them then. And I'll start testosterone and DHEA. There are some women who come in, they're 2 years in menopause, they're 5 years in menopause. From testing 1,000 women, I can tell you, it's so unlikely that they have androgens. Sometimes when it's severe, I'll start out with a steady dose, a small dose of testosterone plus DHEA right out of the gate.
Right.
And then once they adjust their biased and progesterone into a good symptom zone, I'll then start having them titrate or gradually increase the testosterone to find their optimal testosterone dose.
Okay.
And the most common thing we do is we start a woman off with biased and progesterone. And once she gets those regulated and she feels better, we test her usually at the 3-month mark.
Okay.
And then I learn about her androgens.
Right. Right.
And, you know,
yeah,
9 out of 10 women need it.
Yeah, I would agree. I'm one of those women. So, yeah. So what's your best, and this is a good question because I hear contradicting, opinions on this. What do you like? Obviously you like the topical progesterone the best, but has there ever been, or is there a time that you recommend oral progesterone?
There is.
Okay.
Unlike administering biased or any kind of estrogen or testosterone orally, which I'm very much adverse to for reasons that I can specify in the book or in further questions, oral progesterone seems to work out quite well.
Okay.
Almost 100% of the time, I'll start a woman off on topical progesterone. And especially the younger women, their skin absorbs well, they don't need a lot, and they do really well on the topical. And that's always my preference. But I'd say 50% of the women I work with eventually get into oral progesterone. I mean, we're asking a woman's body to absorb a lot more progesterone than we are estrogen, as I illustrated by the need there. So you can only make these progesterones so concentrated for topical use.
Right.
So my preference is transdermal, topical, or vaginal.
Yep. But
sooner or later, not in all women, but in a lot of women, we'll switch to oral. And I tend to use much lower doses of oral than are out there. I mean, the pharmaceutical produces 100 milligram and a 200 milligram. Most of the women I work with are on somewhere between 25 and 75.
Okay.
Now that's a technical issue that the prescriber is going to have to work with.
Right.
There's reasons why we like to go only that high, and there's very few women who need more than that. Some women do. If we get a special sleep benefit of by 100 milligrams of oral or 125 milligrams of oral, that's as high as I've ever had to go. I'll go for the sleep benefit, no matter what it does to the metabolites, which will be different.
Yeah, sleep is that important for sure.
And that's when I'll go to oral progesterone as well. The way that progesterone is metabolized, if a woman has a tough sleep issue that we can't easily address with biased and progesterone, which usually you can, topical. If she's got a tough sleep issue, I'm going to try oral progesterone and I'll have her gradually increase the doses and see if we can get her back to sleep in that regard. When you hear the story of a woman who she never had sleep issues in her life until she went into menopause, and now she's got sleep issues galore, and the estrogen didn't do it, I'll get her into oral progesterone.
Okay. And is there a precaution or any, Margaret's asking, are there any precautions with using progesterone in a family that has maybe breast cancer or anything like that?
Here's another pearl for you. And I'm glad we got to this. There's a book out there, and I'm going to type the name of it in here.
Okay. And guys, remember, as you're thinking of questions here, we got about 10 minutes left, and he's giving you a book that's got a lot of amazing information. I have the book, so grab the email address and make sure that you get in on the information you want about the doctors, and then we're going to be sending out the link for the book as well. So check your emails within the next 48 hours is when our replays go out. My team will get that out to you guys for sure.
My spelling corrector wrote the last name wrong. That's the last name. One of the biggest things that a perimenopausal woman faces, or a menopausal woman faces, is fear of hormones. Mm-hmm. And when the Women's Health Initiative study came out in the early 2000s, it scared me too. I had been treating women for 15 years. All of a sudden I'm going, am I putting a woman at risk for breast cancer?
Right.
I did a deep dive into the medical literature, and I came out the other side and said, not if I use bioidenticals.
Right.
Here's the latest scientific update that Dr. Blooming and Tavris do a fabulous job on in that book, scientific job. Here's the statement you want to know. That a woman treated with Prempro, that's horse urine-derived estrogen and a very funky progestin called Provera, has less of an incidence of breast cancer than a woman who is untreated. That's different than the study originally exploded out into America. Well, they knew by 2006 that was wrong.
Right.
But they couldn't get the cat back in the bag.
Right. I remember all of that. My gosh. Yeah. What a disservice. Yeah.
A woman who's had breast cancer and has had the breast cancer treated has less of an incidence of recurrence if she's treated with Prempro than she is if she's treated with nothing or tamoxifen. Mm-hmm. And a woman with the BRCA1 mutation that puts her at 4 times greater risk for breast cancer has less of a risk if she's treated with Prempro. I'm mentioning Prempro because to me I've never prescribed Prempro. Right. I love bioidenticals. Why not use the same molecule?
Yeah.
But I want to give you those facts because that's the most important thing I think a woman can know. Because we don't want her rubbing hormones on her body twice a day and going, but still I could get breast cancer.
Yeah, we don't want that stress for her or worry.
So this should really alleviate it. It's not like we're not all vulnerable to cancer. We are. And women are still vulnerable to breast cancer, but the risk is less with hormonal treatment. The other thing I'd like to mention, Carmen, is I think it's good for a health coach to steer a woman into the type of topical hormones she takes. Because forever, these topical hormones have come in these jars or click bottles or pump bottles, and 99.3% of what's in that jar is solvent. And only 0.7% is hormone. And to make a long story short, I started to investigate. I uncapped a jar in the 90s and smelled it and went, oh, what is this? I've never seen a hormone before. What is this? And these, we're going way out of our way to discourage all of us to taking any kind of toxins into our body, including solvents. Mm-hmm. And here, the women who are on bioidentical hormone replacement, 99% of what they're taking is a toxic solvent.
Yeah, it's fillers and things that are in the pills and the supplements and the medications and the creams that we're using. Those are just as I just talked about this yesterday about looking for fillers. Can you tell us real quick what the name of the book is by the last name Blooming? I see the last name here, but I see.
I thought I typed it in there. It's called Estrogen Matters. I'll type it in again.
I got it. Already done. Yep. They didn't see it and I didn't either. So I got it typed in. So Estrogen Matters is the name of the book. The last name is Blooming. Okay, let's continue with questions. We're running tight on time here.
So I did want to mention that the antidote for those solvents
Yep.
is these organic oils that we've invented.
Right. Yeah.
Certified organic oil mix there that are good for the skin and good for the body. You don't have to have these applied to a woman in those solvents.
Right. My pharmacist has them. I just wish she'd get the training done so I could use her. I made that introduction. I'm still waiting. And trust me when I tell you impatiently, I'm waiting impatiently. Okay, we've got a couple more questions. So Bobby is asking, what should be the beginning steps to start determining if a person has the checklist of symptoms? Like you mentioned breast tenderness, you mentioned cramping, we know fibroids, endometriosis, things like that. So are there any like ones that stand out? Someone comes to us and what are the top 5 symptoms that you see that someone's starting to experience that major decline of hormones?
Hot flashes and warm rushes and sleep disturbance.
Okay.
Energy decline, muscle weakness, loss of libido, loss of drive.
Yeah.
Active women in business, they lose the aggression and they feel it.
Yeah.
Depression. But let me go back up again. Hot flashes, warm rushes, night sweats, sleep disturbance.
Yeah.
Weight gain.
Mm-hmm.
A woman who's been controlling her weight well and is careful and she's putting on weight in the wrong places, there's a metabolic disturbance there from low estrogens. Those are the big ones.
Okay.
Hot flashes, warm rushes, night sweats, sleep disturbance, energy decline, libido loss.
Yeah. Okay. Linda's saying, do you like to use supplements like DIM? And does the 24-hour urine show estrogen metabolites to know if these types of supplements would be beneficial?
It's the only one that I feel 100% confident in as far as the metabolites go. I like DIM. I just prescribed some today, but I do it when there's a specific change in the metabolites. And for those of you who understand that, there's less 2 and more 16-alpha hydroxy. Mm-hmm. I like the DIM for that. Okay. Because of time limitations, I don't think I should go into that one, but I do like DIM. But I like to do it in conjunction with a test. I don't know that you just shoot from the hip and give someone DIM.
Yeah, I would agree.
The biggest problems people get into is inappropriate dosages, inappropriate balance. Too much or too little estrogen, too much or too little progesterone, too much or too little testosterone. We want them all in a specific target that in the menopause method, we have very carefully defined. Yeah. Anyone who really wants to learn their stuff can become a member in the menopause method. There's no charge for a year. You get access to 13 hours of a professional grade training program about menopause if you want to go that far.
Yeah. Yeah. And I believe Linda's even one that's in it right now, I believe. So this is a good question too, and one I've often, heard, I've wondered about myself over the years, but what are the recommendations? Do you have any recommendations for over-the-counter progesterone?
Yeah, I don't know the brands very much. I know Dr. Lee has a brand, but just grab any of them. They're usually 1.8%. They're pretty weak, but they'll do a job. Yep. And my favorite is the one we're coming out with.
Right. Yes.
Because it's in the organic oils. When you open up that jar of progesterone, 99% of it is going to be the solvent.
Yes. Yeah. So watch the fillers. Watch what the solvent is.
It's not so much the fillers. It's the steroid hormones are very poorly soluble. You need strong solvents to get them into solution. Mm-hmm. That's why they use strong solvents. They can't get a uniform dose. They can't get them into solution unless they use something strong. Like in chemical textbooks, they'll recommend alcohol or acetone. These are super strong solvents. Now, you don't have to do that.
Right.
But that's why we want to bypass those solvents with an organic oils mix. Okay.
So we are at time here, guys, but the one question I think we need to dig in. Let's give it about 5 minutes of depth. The testing conflict, the Dutch test, which is dried urine, and your 24-hour urine test that you recommend. And I'm curious too, this is a selfish question as well as everyone else interested as well. What are the differences and where do you get the 24-hour urine test if we don't have a doctor that practices your method in the state that we're in? That's where I am right now. I'm there right now. I don't have anyone here. So
that's the problem.
Yep.
First of all, I'd like to say that I really appreciate the enthusiasm. And I'm a believer that it takes an army
Mm-hmm.
of health professionals to help get this country healthier. And so I'm happy to come back, Carmen.
Yeah. Well, let's do it. Let's just
If
do
the
it.
interest is there, this is one of my favorite things to do, is to answer specific questions.
Okay. Well, I'll tell you, why don't we do this? Let's talk about the testing, but let me just throw this out there for you guys. I will grab the questions that we didn't answer today from the chat after I convert everything, and I'll hold them for our next talk so that everybody gets their questions answered. But let's go ahead and I'll get my team in touch with you. We'll do this again, but let's give me a little bit more information about the testing for sure. Let's just kind of throw a little teaser out there, and then we'll really go into depth on our next call for sure.
I don't know how to get over the hurdle that health coaches can't order the testing. But one thing, and I know this isn't direct answer to your question, it is not a good idea to test a woman prior to treating her at all.
Okay.
What? Not good to test her. Here's the issue. And I've got a slide for this, but I'm a little concerned it would be a little too hard for me to find. I showed you that nice sweet curve of estrogen and progesterone, really nice sweet curve. Well, when a woman starts getting declining estrogen, let's just take that one. The pituitary gland doesn't like it, or something in the woman's body doesn't like it. Oh my God, we're losing the ovary here.
Yeah.
So it ramps up a stimulatory hormone from the pituitary called FSH, and it jolts that ovary. And my goodness, that ovary blasts out a bunch of estrogen. But the ovary is fatiguing, and it can't keep it up.
Right.
So if you look at the nice, sweet curve of a perimenopausal woman, you don't see that. And this is a woman who's menstruating. You see something like this, estrogen.
Right.
Low valleys and high peaks. The low valleys trigger the FSH. A burst comes out, so you don't know when you're testing her. How did I learn this? I had a woman that come to me with hot flashes and other symptoms of estrogen deficiency. She was in the perimenopause. She was still having periods. I tested her, and I caught her on one of those peaking days. And she saw the report said high estrogens. And I said to her, but I know you need estrogen. And she said, she looked at me like,
yeah,
you tested me and I've got high estrogens and you're telling me that you're going to treat me with estrogen. That was the last time I tested a perimenopausal woman. In our professional teaching, we recommend that no one gets tested in the perimenopause. You're going to wind up with information that's going to confuse you. That has nothing to do with the test method.
Okay.
No matter what test method you use.
Right.
Now the question is, why do you want to test a woman in the menopause? Well, I did. Every woman that came into me in the early part of my career, she tells me I haven't had a period for 2 months or 2 years, and I've got all these symptoms. I said, we'll test you and then we'll treat you with diabetes. Yeah, what did I learn? That every single one of them were on way low estrogen, way low, almost nil progesterone.
Right.
And I was learning what I had already learned about them from the symptoms.
Yeah.
And I said, well, isn't that terrific? I've just given this woman the privilege of paying $280 to learn exactly what I knew when I interviewed her, and it doesn't help me a bit.
Right.
We test 100% of the women that we treat, 100%. But we don't test them until they say to us, hey, I think we figured out this hormone levels for me. That's usually about the 3-month mark. And then we test them annually with 24-hour urine hormone tests, which is absolutely the gold standard.
Yeah.
When you start messing with periodic sampling of urine, you're dealing with bladder concentration issues. You're dealing with different amounts of estrogen and progesterone that occur. So you take 5 samples. When did you take them? And they're going to be erratic. But the biggest issue is around, they're comparing it with the concentration of creatinine. And that is a faulted method. And this whole method derived from a blood test method comparing with creatinine, the finger stick that eventually went bankrupt and got taken off the market. It was a widespread, and I know I'm racing through this topic, but the biggest piece of information is I know a physician who's been testing women with 24-hour urines since the 80s. And he does, and he felt the economic pressure of, he owns a laboratory, and he felt the economic pressure that the 5-point urine was doing, so he decided to do that as well. Mm-hmm. We lecture annually at a conference, and a year ago I asked him, well, what do you think of this 5-point? I already didn't believe it worked. He said, don't like it for women. Yeah. And the other one, there's more to it, but I'm not adverse to any method if it works. But here's my biggest recommendation. I know I'm repeating myself. Don't bother to test a woman who's in the perimenopause. At worst, you're going to confuse her.
Wow. I've never heard that before.
You're not going to learn anything.
Yeah.
That you didn't learn from symptoms.
Right.
Don't test a woman in the early menopause. You're going to be wasting her money. And you'll learn what I learned. And test 100% of the women once they've arrived at the proper dose. But that'll be in the province of the prescriber. Right.
See, I think that way about food. I think everybody's all about allergy testing and food allergy testing. I'm like, why don't you just go to a benign food plan, take out the common allergens, and let's just see what happens. Let's not, the stress and the money and the time invested in all of these food allergy testing and leaky gut testing and all of these. How about we go gold standard with that and just take everything out and start with the things that are the least inflammatory and a very basic benign plan and see how the body responds. To me, that makes more sense. I call it the BEP, the backwards elimination plan.
And you know what? Back in the day, before all these fancy tests were around, we had to do it. And some of the best work that was ever done was an allergy elimination test done in a Dallas hospital by William Ray, a very famous allergy. And what he did is he put these people in a stainless steel ward with totally controlled clothing and air, and he put them on water. Mm-hmm. These were the severe of the severe. They had intractable asthma that they couldn't even treat with medications. And then once they were on water for a couple of days, their asthma would calm down.
Yeah. Isn't that crazy? Well, the immune system.
At a time.
Yeah.
And he'd choose a food that was known not to be very provocative. Hey, let's give them carrots all day long. And if they didn't get a wheeze, day 2 has a new diet called carrots and steamed greens.
Yeah.
And if they don't get a wheeze, then and you build a diet back. And like you were saying, you keep your hands away from wheat and these known provocative foods. Mm-hmm. And you build so even a health coach could do the state of the art, because one of the most knowledgeable physicians in this area taught me the allergy elimination diet, and that's it. But your version is much kinder.
Mm-hmm. I agree. And I like a tea, herbal tea, sometimes bone broth, but wilted greens like spinach and kale and carrots or sweet potatoes. And I put it all in the broth with some, Himalayan sea salt. And I think a 3-day method of that gives you the minerals you need, keeps you from going into any blood sugar issues, really eliminates any of those feelings, like you're starving because you're getting filled up. But then after that 3 days, your body should have some sort of a reset, unless you have histamine issues or whatever. But it's a very basic plan. And boy, did my clients love me when I said, no, we're not going to do that big, take it all away from you, make you feel like you're losing your life. Let's do something simple, and let's remove the stress from it.
Right on. And the test that I've described was very extreme. These people, they couldn't control their asthma.
Yeah.
With the strongest medication. So they were willing to go on water, but you're so right. Of course. That's very stressful to a body to go on a water fast for 3 days.
Yeah.
I like your method much better for the usual public. Absolutely.
Yeah, Joe Public. Okay. Great. Well, we've got obviously more topics that we could talk about. So let's get you back in here. My team has your information. We'll get another date on the map. I will pull from the chat. We will get the book sent out PDF style to the replay. And again, Dr. R at menopausemethod.com, you guys, to get on the list to find out more about the nurse practitioners and people in your state that can also assist you for referrals or even learning more for yourself. Because I know there's probably a lot of people on here that benefited personally, just like I did today. So again, just appreciate you. Love the interview I did. for your summit and just everything you guys are doing. Just kudos and much gratitude to you.
Thank you, Carmen. Thank you, everybody.
Yep, appreciate it. Bye, guys. Replay goes out soon, Jody. Bye, everybody.